Today we're going to talk about lung volumes, their measurement and normal values. Lung volumes are usually measured using spirometry. Initially, the patient is asked to take normal, quiet inspiration and expiration. This volume is known as the tidal volume, and this in normal adults averages around 500 mils. From the end of normal inspiration to maximal inspiration is known as the inspiratory reserve volume. And this measures around 3,000 mils. Then if a patient was to return to normal quiet breathing, but at the end of expiration take a maximal breath outwards, this volume is known as the expiratory reserve volume and measures around 1,000 mils. The volume of air left in the lungs after maximal expiration is known as the residual volume, and this also measures around 1,000 to 1,200 mils. So you can see here that spirometry is used to measure three lung volumes: the tidal volume, inspiratory and expiratory reserve volumes. Capacities cannot be directly measured by spirometry, but can be deduced from the values of the volumes measured. The definition of a capacity is the sum of two or more volumes. So we'll talk about those now. The inspiratory capacity is the tidal volume plus the inspiratory reserve volume, and equals 3,500. The vital capacity is a volume that can be breathed out from maximal inspiration to maximal expiration. So it's an inspiratory capacity, and this is vital capacity, which equals 4,500. The total lung volume is the vital capacity plus the residual volume. Total lung capacity, which equals around 5,500 mils. The last capacity is the most clinically relevant capacity, and it's known as the functional residual capacity. And this is a sum of the expiratory reserve volume and the residual volume, and equals around 2,000 to 2,200 mils. This is the volume of air in the lungs when the elastic recall of the lungs equals the outward force of the chest wall wanting to expand. It's important as it acts as an oxygen reservoir, maintaining oxygenation of blood passing through the pulmonary capillaries during expiration or breath holding. And in the clinical anaesthetic setting, this allows for time to secure an airway at the beginning of an operation without causing desaturation in the patient. Functional residual capacity can be increased when the patient's height's increased and in males, and it's important to note that it can decrease up to 1,000 mils in the supine patient due to the upward movement of abdominal contents. Thank you. So we've just talked about spirometry, but as we discussed, it is impossible to measure the residual volume, and therefore you're unable to work out the total lung capacity or the functional residual capacity. So now I'll talk about the techniques that are used to measure the functional residual capacity. And the first one is known as helium dilution. So in this, there is a known reservoir of helium with an ability to measure the concentration inside the reservoir. And this is connected to the patient via a mouthpiece that can be open and shut. So initially the patient takes in normal breaths, and at the end of quiet expiration, also known as the functional residual capacity, the mouthpiece opens. Then, with each breath, helium moves into the lungs until a new equilibrium is reached and the concentration can be measured on the dial. As this all is a closed system and helium is insoluble in blood, the initial amount of helium, known as helium I, will equal the amount of helium at the end, helium E. So the initial amount of helium can be measured by the initial concentration times the initial volume. And as we mentioned above, this is going to be equal to the end, the new concentration of helium, which can be measured by the dial, times the known initial volume plus the functional residual capacity. So we can rearrange this to work out the functional residual capacity, which will be equal to the initial volume times the initial concentration minus the second concentration divided by the second concentration. The advantages of this technique is that it's simple and relatively inexpensive. However, the main disadvantage is that it only measures the volume in the chest that communicates with the upper airways. Therefore, it is not accurate in patients with bullous lung disease, such as emphysema, because if the bulli don't communicate with the upper trachea, then it will measure an inaccurate functional residual capacity. Thank you. To measure the functional residual capacity is to use whole body plethysmography. In this, there is a glass box with a tube connected to the outside world. This has a mouthpiece inside the box and a valve which can be opened and shut outside the box. There's also a pressure transducer which is able to measure the pressure inside the box and the pressure inside the mouthpiece. The patient sits inside the box. Their lungs, and they are asked to pant. They're panting whilst the mouthpiece is open, and then the mouthpiece shuts, and they continue to pant. Oscillations in the pressure in the mouthpiece and the box can be measured by the pressure transducer. This whole technique relies on Boyle's law, which states that the pressure and volume inside a closed system is constant at a constant pH, a constant temperature, sorry. Therefore, if the pressure inside the box before and after is known as P1 and P2, and V1 is the volume inside the box, we can work out the change in volume with expiration. This is known as P1, V1 equals P2 initial volume minus the change in volume. Next, Boyle's law can be applied to the gas in the lungs. So this calculation is P3 times V2 equals P4 times V2 plus the change in volume, which you've worked out from the last equation. So here, P3 is the pressure in the mouthpiece before the valve is open, and the pressure P4 is the pressure afterwards. and V2 is the functional residual capacity. The advantage of this technique is that it's much more accurate. However, because of the specialised equipment needed, it is the most expensive technique. Thank you.